Hello and welcome to the Sisters for Fitness Wellness Show. I'm Stephanie Gaines Bryant. Our guest today is Dr. Joan Parambi, and she's an endocrinologist. Today we're talking about some things that affect the endocrine system.
Sure.
And we talked about diabetes. This is part 2 of our program. Right. The first part of the program we talked about diabetes. This part of the program we're going to talk about other conditions that deal with the endocrine system.
Sure.
I want to start off with something called polycystic ovarian syndrome. Okay. And exactly what is that?
Right. Polycystic ovarian syndrome is a syndrome. Basically what that means is you have, the criteria has changed over the years, but the most the agreed upon criteria is if you meet 2 out of 3 criteria, you have the condition. It's basically symptoms of anovulation or oligomenorrhea, where you have infrequent cycles and that results in infertility. You have hyperandrogenism, where either biochemically or clinically you have evidence of excessive hair growth or acne or just too much male hormones in women. And radiological, so that's based on an ultrasound of the pelvis. Your ovaries look a certain way, where you have multiple follicles and they meet certain radiological criteria. So if you have 2 out of 3 criteria, you have the condition. It's a syndrome. Unfortunately, there isn't one test that we can do to diagnose it, but it's a syndrome.
What does obesity have to do with? How is obesity linked to PCOS?
Right. So PCOS is a condition where if you do have obesity, about 50% of patients who have PCOS have obesity. So it's not a must that everyone with PCOS is overweight or obese. But if you do have obesity, it amplifies some of the complications or the symptoms of PCOS.
So what are some of the things that we can do nowadays? I know a couple of years ago I was diagnosed with it. My sister had it. My mother had it. So we can talk about the whole genetics thing of that as well.
Yeah, so at this point we think it's pleomorphic. That means it's not just one gene that is passed on, but there are multiple candidate genes that they've looked at through GWAS studies, which is the genomic wide array studies, and they've come up with multiple candidates, and some of these genes are only associated with PCOS, some of them are associated with PCOS and insulin resistance, which is where the obesity thing takes place. But if you have a sister or mother with PCOS, up to a 40% increased risk of the other female sibling or offspring having PCOS. So there's definitely a genetic predisposition.
What can we do about it at this point? And you mentioned that one of the symptoms is not having menstrual cycles. So that's a sure sign right there. Right. That you may have it.
Yeah, so it's one of the criteria, but there are many reasons, especially in young women, teenagers, multiple reasons for irregular cycles. So just because you have irregular cycles, we can't say PCOS, but the important thing about missing your periods, if you have PCOS, is the first half of your cycle. So your menstrual cycle is divided into 2 halves. The first half is where the egg is being is maturing and your uterine lining is forming, and in the second half is when the egg is released and then you shed your uterine lining. In PCOS, the uterine lining keeps being built up, but the shedding doesn't happen. And when you go multiple months without having a period, you're worried about your uterine lining building up, and that can increase what's called abnormal cell buildup or endometrial hyperplasia, and as you grow older, increases risk for cancer, endometrial cancer or uterine cancer. So it's important that you shed that uterine lining. Initially they said every 3 months, so you need to have a period at least every 3 months, but with the concerns with hyperplasia, now they're saying you should have a period at least once a month.
So does that mean birth control pills?
Right. So so the main thing is, if you are overweight or obese, try to lose weight. When you lose weight, most women tend to get their cycles back, but that takes a while. Or if you don't have much weight to lose anyways, definitely look into birth control so that you are able to shed the uterine lining.
And there are other medications as well that are not birth control pills that you can take for a certain number of days, and it'll cause your cycle to come on on as well, so you don't have to take the daily birth control.
Right. So yeah. So the birth control. So if you are, so there's birth control is estrogen and progesterone. That's the kind that you take every day. And if women have PCOS, the other benefit of taking certain types of birth control is it can block the testosterone effects. So some of the newer birth controls can help with acne and the hair growth that you see. So you get regular cycles, and you can also block some of the testosterone effects. And then there's a contraceptive aspect if someone is looking for that. But if they don't need any of that, then you can just take a progesterone tablet for 10 days at the end of the month so that you get a period. So if you don't want to keep taking a tablet every day, that's another option.
Once you're at an age where you want to start having children,
Right.
what are some of the things that you can do to increase your chances of becoming pregnant?
Right. So the thing with PCOS and infertility, the main thing is you don't know when you are releasing the egg, because you don't release an egg every month. So the main thing is about timing intercourse with the ovulation. So that's why a lot of patients have infertility. So it depends on the age of the person and how soon they want to get pregnant. If you're talking about someone who is younger, and if they are overweight or obese, because PCOS increases the risk for other metabolic diseases like fatty liver, high cholesterol, triglyceride issues, and prediabetes, I usually ask people to focus on the weight loss and correcting your metabolic parameters. And as you do that, the cycles get regular, and once you have regular cycles, they become more predictable, and then you can time intercourse and get pregnant that way. But if we're talking about someone who's older, then we recommend, above 35, 40, your fertility is already reducing and we don't have the luxury of time. Then in addition to making all the changes for metabolic improvement, we usually refer them to reproductive endocrinology.
So usually you have to do some sort of assisted reproductive technology.
Basically to come up with when to predict when ovulation is happening. So they have something called clomiphene or Clomid, been around
Yes.
for a very long
Yes.
time. The good thing about that is you just take it in accelerating doses, but you can predict when ovulation happens. You're kind of forcing your ovary to ovulate, then you time intercourse, and then there's IVF, artificial
Yes.
insemination. Yeah.
Also ovarian drilling, do they still do that nowadays?
I don't think they do that. That's more for a reproductive endocrinology, but I think that's something that they used to do to reduce the bulk of the ovary. I don't think they do that very commonly anymore.
Another condition is thyroidism.
Right.
And your thyroid can be too active or underactive.
Right.
So can you talk a little bit about that?
Right. So thyroid conditions are again common. It's more common when you have a family history. So women in the family usually tend to give it to more women. If the father in the family has it, the chance of both the kids getting it are much higher, the men and the boys as well as the girls. And it can go either way. You can have overactive thyroid or underactive thyroid. And the symptoms are opposite for each one of them. So in hyperthyroidism, it's like being on 10 cups of coffee a day, hot, sweaty, shaky, losing weight without trying. Hypothyroidism, that's when you're underactive, is when you gain weight without trying, dry skin, constipation, depression, depressed mood. So they're diametrically opposite. You can go either way.
People, so you're saying people with an underactive thyroid, how do you manage your weight then?
Right. So the symptoms of hypothyroidism, I usually tell patients, aren't exclusive to hypothyroidism. So when you are underactive and if you're untreated, then you gain weight without trying. So it's important to detect it and treat it if you meet the criteria for treatment. And but once we start treating you and your levels are where you need to be, that shouldn't prevent further weight gain. So, but just because you're treated, you don't lose the weight that you get. So a lot of patients think, oh, I'm gaining weight because I'm underactive. We put them on medicine and we normalize their levels. They think that they'll just magically lose all the weight. That doesn't happen, unfortunately. You lose weight without trying only if you're on too much medicine or you become overactive.
So it takes time to kind of find the right level of medicine that will work for you.
Yeah, so it depends on your inflammation. So people who are burning out your thyroid fast, it might take a couple of weeks and months to monitor your levels, get you where you need to be. But once you get there, I usually tell patients, do what you're doing with the diet and the exercise. You'll need to ramp up the exercise to lose the weight that you've gained, but there's nothing stopping you from losing it.
Can having an underactive thyroid, can that also lead to infertility?
It can. So what we have is, what happens is when, so it's important that your levels are normal before you try to get pregnant. So if you have a thyroid condition, we usually tell patients to check your levels before you're actively planning pregnancy. And then when a woman gets pregnant, if your thyroid gland was intact, what happens is your thyroid produces extra, about 10 to 30% extra thyroid hormone for you and the developing baby, because the fetus doesn't have a fully functional thyroid gland for the first couple of weeks, for up to 10 to 12 weeks. So it's most women who are on thyroid medicine need to be monitored. As soon as they find out they're pregnant, they need to increase their thyroid hormone dose by 10 to 30%. And if you don't do that, you can have subclinical hypothyroidism or overt hypothyroidism that can increase your risk for miscarriages and cognitive development in the child.
Are your risks for miscarriage high as well with polycystic ovarian syndrome?
Yes, there is a slightly increased risk for PCOS.
And why is that?
We don't know as yet, but it's probably to do with the quality of the egg or any of the other metabolic factors, if they have diabetes and all associated with it, but it's still, we're not really sure.
Let's talk about what medications are available for thyroid.
For an underactive thyroid, we have levothyroxine. It's a synthetic thyroid hormone. They have different brands. They have the generic brand. They have the brand name Synthroid. They have brand name called Tirosint, which doesn't have any fillers if you have reaction to the other brand names. And then there's T3, which is a liothyronine. Very few people need that if they don't respond symptom-wise or if they have thyroid cancer. But it's usually synthetic versions of the thyroid hormone that your body produces.
When you have an overactive thyroid,
Right.
is the goal to gain weight?
No. So when you are overactive, you lose weight without trying. And now the goal is to get your levels back to normal. We don't want to make you underactive, because an overactive thyroid can increase your risk for an abnormal heart rhythm, osteoporosis. If it goes really out of control, you have something called thyroid storm, which is where you can get seizures and high blood pressure, high body temperature, 30% chance of dying from it. So it is one of our very few endocrine emergencies. So it's important your thyroid doesn't go so high as well. So we need to normalize you. We try to bring your levels back to normal. So we have a class of drugs called thionamides, like methimazole, PTU. That's what we use to bring your levels down to normal. So the goal is not to gain weight. Some people might gain weight just because they're trying to gain the weight that they lost, but the goal is not to make you, the weight is not really what we're looking at. We're looking at your levels.
Is it something that having thyroid issues, is that something that can happen later in life, or is it something that happens early in life? At what point in life should that be a consideration? Should you consider, hey, maybe there's something going on with my thyroid?
So it depends on your family history. So if there's a family history of thyroid conditions, I usually tell the parents to make sure the pediatrician is aware, because at any point if the child is going off the growth curve or if there's any behavioral issues, that's something that they may want to check. It's a quick lab test that they can do.
What would behavior have to? That's interesting.
Yeah, so if there is hypothyroidism and depression, mood disorder, you know, that can be there, that can be seen in younger children. And then if someone is all of a sudden diagnosed with hyperactivity, they could just be overactive. So if there's a family history, it's important that the pediatrician is aware. And it can go either way. So a lot of these thyroid conditions are immune based. So it's your immune system attacking your thyroid. and it can cause blocking antibodies which make you underactive, or stimulating antibodies that can make you overactive. So there are families where you have overactive and underactive thyroid conditions. So it's important that the pediatrician is aware. In men, thyroid conditions can happen at any time. In women, I've seen thyroid conditions happen more during periods of hormonal changes. So around the time when kids are going through puberty, or after delivery, the postpartum period, and then menopause. So because the hormonal changes does something to your immune system. So if you have the genetic potential for autoimmune diseases, usually tends to happen during those times.
So is it more common in men or women?
Thyroid conditions are more common in women, but if there's a family history of thyroid condition in the parents, it can happen in either.
And the treatment is the same for both men and women?
Correct.
And the men experience the whole mood changes and...
Yeah. So actually men are more sensitive to some of the TSA changes more than women, because our bodies are used to hormones going very wacky with pregnancy and menopause, but men are actually more sensitive to it. They tend to brush off symptoms, but they actually notice once they start treatment, they are more sensitive to the changes than women are.
Let's go back to PCOS for just a moment. Once you get in that perimenopause, menopausal stage,
Right.
do the symptoms go away, or do you forever, once you no longer have a cycle?
Right. So the missing of the cycles are not as much of a problem once you go through menopause. But if you also have the insulin resistance gene along with the PCOS, the metabolic factors still persist. So some of the hair growth issues, because in PCOS, the ovary is a main producer of the testosterone, which causes the hirsutism and the acne. So some of those symptoms do get a little better now that your ovary is no longer functioning, but the metabolic factor is still there, especially with menopause. Weight gain is common. So if you have insulin resistance, and then the weight gain associated with PCOS can really push you over the edge and cause diabetes, fatty liver.
Wow.
Yeah.
What about age as a factor when it comes to thyroid? Once you get to a certain age, is it more common or less?
So there is a type of age-related hypothyroidism where, as we grow older, your thyroid levels do go down a little bit, but that is a different condition in itself, and there's a lot of studies going on. Should we treat it? Should we not treat it? Is it a natural phenomenon of your body just lowering your metabolic rate as a part of aging because you don't want to be so ramped up? So the age-related hypothyroidism is a different condition from what we see in younger people, and you only treat it if there are certain risk factors like heart disease or something. But usually we are pretty conservative when it comes to treating age-related, like 70s, 80s, and above.
What other conditions do you deal with that deal with the endocrine system?
So there's the adrenal gland. So we deal with things like Cushing's disease, Cushing's syndrome with the adrenal gland, and there are tumors that you can find in the adrenal gland that produce excessive adrenaline or blood pressure producing hormones like aldosterone. Then there's the pituitary gland. That's the master gland. There's growth hormone, prolactin, and then we deal with osteoporosis, bone, hormone-mediated, so postmenopausal osteoporosis, steroid-induced osteoporosis.
What osteoporosis is, it's a bone
Condition, yes.
condition.
So that what happens is it's when the bone cells, when you are forming, when you're breaking down bone faster than you're forming. So your bone becomes thinner and thinner with time, and it increases your risk for fractures.
Are there women in certain communities that are more likely to get osteoporosis than others? For example, are Asian women or white women more likely to get that than African American?
Right. Yeah. So there is an ethnic variability in bone density, and African American women tend to have by default a higher bone density than Caucasian women, Asian women. So osteoporosis is not as common for the same age in African American as opposed to Caucasian women or Asian women. And but it's not like it doesn't happen, especially if you're taking certain drugs, like if you're on steroids or if you've had chemotherapy or aromatase inhibitors for breast cancer. So a lot of those things can push you into osteoporosis or osteopenia, which is the precursor, even though you might not be in a certain ethnic group.
What does it do to your bones? Does it make your bones more brittle?
Correct. So because so your bone heals and repairs by breaking down and forming new bone. What happens is after menopause, you are breaking down bone faster than you are making it because you don't have that estrogen protection. So with time, your bone becomes weak. So if you started off at 100% bone density, with time you go down to 90, 80, 70, 60, and as you grow older, your bone density becomes less and less, and it gets to the point where you have fragility fracture, where you can just trip and fall and then you can break your hip or your spine. So, and the morbidity is higher, like if you break your hip or your spine, especially after the age of 70, if you break your hip, there's a 50% chance that you could die by the end of the year. So morbidity as well as mortality is higher. It's basically what happens is it gives you, it tells you, it's a precursor, it tells you what your overall health is like. If you fell and broke your hip, then you're at risk for post-op complications, pneumonia, you're not as independent as you used to be, so that can increase your risk for blood clots. So that way there's a lot of morbidity and mortality associated with it.
What are the medications? I see lots of medications on TV for osteoporosis.
Right. So it's basically two classes of medicines. There are medicines that can reduce bone breakdown, so you're not breaking down bone as fast, and then there are medicines that can actually increase bone growth. So the medicines that increase bone growth are there are two drugs that are out. It's an injection that you have to do every day for 2 years, and so people with very low bone density, or they've tried the older versions that and they kept fracturing, those are the ones that we suggest build the bone, and then we use the older classes of medicines to help preserve the bone that you have. And then the older classes, there are pills that you take once a week, there's an injection that you can take twice a year, and there's an injection that you can take once a year.
What are some of the things that, some of the holistic things you can do? Do you see there are also like vitamins? You see vitamins available for that. Have you seen them be effective, or is that something you would recommend?
So for osteoporosis, I usually tell patients to think of your bone like a building, right? So there is the structural component of the building, like the scaffolding and the steel pipes, and then there's the concrete that goes into the building. So there's two different things we're talking about. So it's important that you take enough vitamin D and calcium, because your bone is 90% calcium deposit. So it's very important that you have vitamin D and calcium in it, because when you do a bone density, it's just an x-ray. It just tells me how thick your bone is. It doesn't tell me is it a calcium problem or scaffolding, like a concrete problem or a scaffolding problem. So osteoporosis is when it's a structural problem. And then the calcium, between people being lactose intolerant or avoiding dairy, a lot of people, we just don't get enough calcium in our diet. So it's important to get calcium in our diet. I'd rather you do it naturally than pop a pill. And then vitamin D is also important because of where we live. 7 months of the year we don't get enough sunlight. So I usually recommend.
People don't realize that is a serious thing.
Yes, it is a serious thing. And then in the summer when we do get it, we're wearing sunblock, which is what we should do because we don't want to get sunburn. But there's always a perpetual deficiency, so which is why check your levels, improve it, and then maintain it. What happens is people take the high dose vitamin D for a couple of months and then forget about it, and then their level goes down again. They forget to take a small dose every day to kind of maintain your level, so that's important as well. And then walking, exercise, weight-bearing exercise.
That's what I was going to ask you as well. If your bones are brittle or more fragile,
Right.
Is it best or worse to exercise.
Right. So you don't want to do any kind of combative kind of boxing or something like that.
No
But
kickboxing.
no, right. So nothing like, I wouldn't recommend that. But no, every time your foot hits the ground, it tells your bones to become stronger. So walking is great. So exercise, I usually tell patients to do, it's a twofold thing. You need to do weight bearing exercises so that your bones become stronger, but also do coordination exercises, because fall prevention is huge in osteoporosis. As we grow older, our muscles become weaker. So things like Tai Chi or yoga that help with maintaining our balance, you know, if you fall, to recorrect very quickly before actually falling and hitting the ground. That's also huge when it comes to fall prevention and osteoporosis.
You mentioned a few minutes ago that you would prefer people getting calcium the natural way opposed to taking a pill.
Correct.
So that way would be things like milk, or what are some of the things you can do to get that calcium naturally?
Right. So we usually recommend you have at least 4 servings of calcium-rich foods a day. So dairy versions, there's milk, cheese, yogurt, and then there's egg. If you don't like lactose, most of the almond milk, soy milk, the non-dairy version is fortified with calcium. And then there's orange juice that's fortified with calcium, eggs, cereals like oatmeal is also fortified, spinach, broccoli, all the green leafy vegetables,
What
great
does it
in
mean
calcium.
to be fortified with calcium?
Right, so orange juice doesn't naturally have calcium in it, so they add calcium to it. So if you had 8 ounces of calcium fortified orange juice, that would be counted as 1 serving.
Okay,
So,
and almond milk and those things
Right,
are
so,
fortified.
yeah.
I've just discovered almond milk and cashew milk,
Right.
and I'm in love.
Oh, you do? Yeah. So it is more processed than cow's milk. So if you don't, so I usually tell patients, if you like to substitute, that's fine. But I'd rather you have a handful of almonds. That naturally has more calcium in it. It's just when you grind it up and dilute it with water, you need to add the extra calcium to it.
And calcium vitamins, you would prefer that? I mean, if you have to take
Right,
one,
if you
fine.
have to take it because you don't like any of these things for whatever reason, that's fine. But there used to be a time where people were taking 1,000, 2,000 milligrams of calcium, and studies have shown taking large amounts of it actually raises your calcium levels, can increase your risk for calcification, abnormal vascular calcification, if you have other conditions going on like diabetes and hyperlipidemia. So it's better to take it naturally. Our gut knows how to regulate things. Just feed the gut, it'll absorb it until, give you exactly what you need. The problem is we don't get enough.
We don't get enough sunlight, we don't get enough.
We're trapped in our concrete buildings all day, yes.
So it's something, it sounds like with the osteoporosis, that can be managed.
It can be managed provided we recognize it before it gets to a certain point, because all the medicines we have aren't very strong. The problem is they improve, the best medicine we have increases your bone density by about 10-12%. So if you keep avoiding medicine till you're down to like 20% bone density, even if you take medicine, there's only so much you can come up to.
Well, it's been a pleasure.
Thank you.
We've been talking to Dr. Joan Parambi, and she's with Doctors Community Hospital. We've been talking about the endocrine system.
Right.
Okay, and all of the conditions that are associated with that. Yeah. You've been watching the Sisters for Fitness Wellness Show. I'm Stephanie Gaines Bryant. Have a great day.